now. And so please do not include any confidential patient health information during the session. Roll call is required for CME or CEU certificates or an attendance certificate if you'd like that. We just require a verbal or chat announcement. We like you to let us know where you're from as well. That helps us with the conversation. If you're in a group larger than 5, then you want to email your list to myself or to Zach. And our email addresses are at the end of this slide set. And certificates are sent out once a month. Joining computer audio and video, those should automatically start up for you, but you can toggle the mute there with the little camera icon or the very old looking microphone as well. It should be down in the bottom left corner for you. If you're using your telephone, you can stop your audio and start it up using your telephone, and you'll follow the instructions there. If you do so, just go ahead and mute your computer mic and speakers to avoid any feedback loops or echoes. And our disclosure and accreditation statements are on screen right now. Case consultation reimbursements, Molina Healthcare and Blue Cross Blue Shield New Mexico Centennial Care do provide some reimbursement for bringing your cases to us. AHI New Mexico does have a component regarding that, so contact me again or Zach about that if you'd like to bring one of your cases, and the reimbursement is significant, so take advantage of that. And at this point, if anybody is on the line or on audio, then please go ahead and let us know you're out there. And with the one exception of our presenter today, we'll go ahead and go around the room and announce who is in the room. So this is Kevin Rolling, Systems Analyst at Nmdoh, New Mexico.
Zach Johnson, Health Education Consultant for Nmdoh.
Carol Conley, Social Worker and Adolescent Health Initiative Facilitator, Nmdoh, New Mexico.
I'm Jane Beckley. I'm a nurse practitioner working with Fronteras here at Nmdoh, New Mexico.
I'm Maya Trujillo, Quality Improvement Specialist with Nmdoh, New Mexico.
Hi everyone, I'm Emma. I'm a social work intern here at Nmdoh, New Mexico.
And I'll go ahead and turn it over to Carol Conley, who's going to introduce our speaker today.
Okay, welcome everybody to Studio Envision. This is the Adolescent Health Initiative, New Mexico. It is our goal to bring you up-to-date information and resources related to the care of teenagers. Excuse me. Today we welcome Daisy Rosero. Daisy is the program manager for the Sbirt, which is the Screening, Brief Intervention, Referral to Treatment program here in New Mexico. And this partnership with Adolescent Medicine and Envision is focused on the training and implementation of the Sbirt model in school-based health centers around New Mexico. Daisy has worked statewide bringing these tools and resources to providers and supporting them in their efforts at reducing substance use and abuse in adolescents. Thank you very much for taking the time and coming and sharing your work with us today.
Thank you. Thank you for that introduction, Carol. And I just want to say I apologize for giving you my back in this situation. We have the presentation in the front of the room, so my apologies for that. So as Carol said, I am the program manager here at the Sbirt program. The Sbirt program was an implementation in school-based health centers. It's a collaboration between the Department of Health, Office of, what is it?
Student and Adolescent Health.
Office of School and Adolescent Health, excuse me. We have lots of acronyms that are sometimes difficult to remember. It's also a collaboration between the University of New Mexico Pediatrics Department and the Center on Alcoholism, Substance Abuse, and Addiction, otherwise known as CASA. The implementation program was funded by the Conrad and Hilton Foundation for the past 3 years. So today what I'd like to talk about is identifying the components of Sbirt, describing how Sbirt is implemented in the school-based health centers, and also talking about how to employ Sbirt, well, really adolescent-specific screening and clinical guidance tools in your practice. So just to begin our introduction, we know that adolescent substance use is a serious health concern in New Mexico and the United States. Rates in New Mexico in particular are higher than national rates in many cases. This slide here is a graph taken from the Youth Risk and Resiliency Survey from 2015. It displays rates of substance use among New Mexico and US high school students. New Mexico is in red and national rates are in blue. So if you take a minute to take a look at this, you'll notice that the red bars are higher across the board. And what we're seeing right here represented are alcohol, marijuana, cocaine, ecstasy, heroin, and methamphetamines. You'll notice that the first bar in alcohol is use before the age of 13. And New Mexico rates are 20% versus the 15% at the national rate. For marijuana, we have quite a serious problem here in New Mexico. Our marijuana use before the age of 13 years old is 16.5%, which is more than double the national rates. The national rates are 7.2. Cocaine, as you can see, is double, also 8.8 for compared to 4.8 in the nation, and so forth and so on. So you can see that it is a public health problem that needs to be addressed here in the state. So why do we want to address this problem? Why do we want to screen for substance use? Well, adolescents who use substances are more likely to suffer from depression and anxiety. They engage in riskier behavior such as unprotected sex, and they have an increased risk of HIV, Hep C, and Hep B transmission. They also experience violence, higher rates of violence, accidents or injury, vehicular injury in particular. And at the end of the day, most adults who are experiencing substance use disorders begin using substances in adolescence or young adulthood. So we really want to use a preventive model to address this problem. So what is Sbirt? That brings us to Sbirt. Sbirt is an evidence-based public health approach to identify, reduce, and prevent problematic use. It really, what it is a comprehensive system, a comprehensive model that really changes the paradigm from a very directive approach to an approach that's based on protective factors. So we're not focusing on the issue once it has become a problem, but we're looking at it before it becomes a problem. And the components of Sbirt, as you can see, are screening, brief intervention, and referral to treatment. A very important part of Sbirt is the inclusion of motivational interviewing as part of the brief intervention. We'll talk more about that in a minute. So what does Sbirt do, really? Well, it provides for universal screening so that you can quickly and systematically assess and identify individuals that are at risk. It provides for a brief intervention. That's the opportunity to engage someone in a conversation, and a referral to treatment. Referral to treatment typically happens for a very small percentage of individuals, and it could be a referral to a behavioral health person, or it could be a referral to an inpatient or an outpatient facility. I did want to say something about the universal screening. Sbirt is endorsed by the American Academy of Pediatrics, and universal screening is recommended, is highly recommended by the American Academy of Pediatrics as being a good fit for all patients. So if you are doing universal screening in your practice, you are you are helping to identify the problem before it really becomes a problem. So this next slide, it really is focused on alcohol, but it does apply to substances, drugs, in other words. The Sbirt model, as you can see right here, we have about 70% of the population that are abstainers or low risk users, and only 25% that are moderate users. At the very, very top of the pyramid, you have 4% who are alcohol dependent. Sbirt is really about taking a look at that 70% and that 25%. That's where we want to affect the most change. So we don't get to that 4% at the very top of the pyramid. So why is it a good fit for adolescents? Well, as I said before, Sbirt uses a motivational interviewing approach. And really what it is non-confrontational. It addresses ambivalence and it builds on self-motivation. So it is more of a conversation rather than a directive for adolescents. While we're not going to really go into motivational interviewing too much, I did want to talk a little bit about the concepts of motivational interviewing. Three of the main concepts are the ability to have a collaborative engagement rather than an authoritarian engagement. So really coming alongside the individual rather than being very directive and telling someone what to do. This particularly works very well for adolescents. And it evokes one's own motivation to change. So you're looking at, how you can help that individual to make the change that they need to make for themselves, not telling them what to do. And lastly, it honors autonomy. It meets people where they are. It also places, in a sense, the responsibility for change in the individual, but it allows the provider to help and support that change without forcing someone to make a change. Four of the core concepts that are employed in motivational interviewing are called the ORs. So they're open-ended questions, affirmations, reflective listening, and summary statements. And each one of these has a very specific reason for being part of the strategy. The open-ended questions allows you as a provider to open up a conversation with the individual. It invites someone to talk about the problem. Affirmations strengthens that relationship. Part of MI is about building the relationship with a young person or with the individual. And then reflective listening will help to clarify any statements that the individual is making. So it helps to make sure that you, as the clinician, understand what that individual is saying. And with your summary statements, you're going to wrap up the conversation, and it also sets you up for that next step. So what do we do next? This is what I've heard from you, and now what do we do next? So why is Sbirt important in a primary care setting? Well, there are three main reasons: access, early detection, and early intervention. About 83% of adolescents will have a medical visit annually. Medical visits, so that makes them an opportunity to open up that conversation, to really ask about substance use. Most young people don't seek out behavioral health services, so this is an access point to those behavioral health services that they might need. So early detection, it helps providers identify substance use. So again, individuals may not be actively seeking care. So this is an opportunity to detect that problem early on. And then early intervention. You have an opportunity to intervene, to affect some change, and to reduce the use of substances by addressing the problem. So I want to switch gears a little bit to talk about what the implementation looked like in the school-based health centers themselves. And this will frame how Sbirt is utilized in a clinical setting. So in the school-based health centers, New Mexico school-based health centers, the program was designed to deliver tools and training. In other words, provide the screening and the clinical guidance tools to the providers to train them in Sbirt and motivational interviewing. And we not only trained providers, but we also trained the staff. Staff are an integral part of the Sbirt system because they are that first person that a patient sees when you walk into the clinic. And so in school-based health centers, we actually implemented Sbirt in 32 school-based health centers out of the 42 that are available for high school students. And the sites received electronic screening tools, and they also have specialized reports to expedite that assessment for the clinician. We currently do not have the screening tool available for the general public on an iPad or electronically, but we do have it available in a paper format. So why is it important to implement Sbirt in the school-based health centers? Why did we find this a good venue? Well, we know that in school-based health centers, we have confidential services. So young people, adolescents, can go into a school-based health center and understand that they have some privacy, that there is some confidentiality with the information that they share with providers. It's also extremely convenient. Most of the school-based health centers are located on a school campus or very, very nearby. So it makes it very easy for young people to access the services, whether they're medical or behavioral health services, within the school day, without having to miss an entire day. School-based health centers also implement an integrated care model. And for those of you that are not familiar with that, what that means is that there's a primary care provider as well as a behavioral health provider on campus. And that really helps with the referrals to treatment, because you as a provider can go and do a warm handoff for someone who is needing a little bit more support or care. And one of the most important things that we found in school-based health centers in New Mexico is that they universally administer a standardized screen. The standardized screen includes social emotional questions and content, but it also includes the craft. And the craft is that evidence-based adolescent substance use screen that is actually very well studied. CRAFT stands for a myriad of information. I'm going to read that off now because I think it's important to review this part. The C is for ever ridden in a car with someone, including you or someone who was drunk or high. It asks about ever using alcohol or drugs to relax, feel better, or fit in. Ever used alcohol or drugs while alone? Ever forgotten things while you were using drugs or alcohol? Have family and friends ever told you to cut down on your drinking or drug use? And have you ever gotten into trouble while you're using drugs and alcohol? So as I was saying, the CRAFT is one of the most extensively researched substance use screens. And it's especially useful because it is very quick. It's 6 questions where a positive screen would be indicated by 2 yes responses or more. And it screens for both alcohol and drugs. It's not just one of those things. Now, one of the things that what we do like about it is that it is a quick screen. However, the time frame is a little bit longer than was necessary or what was needed here in school-based health centers. The time frame here for the CRAFT is a 12-month or ever time frame. And it also lacks the specificity that a provider might need to respond effectively to a problem substance use. So in the last 2 years, we found that there are 2 new screens and a clinical guidance tool that could better address that specificity that a provider needs to look at substance use risk. Excuse me. And one of those screens is called Screening to Brief Intervention, or the S2BI. This was recently validated in 2016, and it addresses all levels of risk from abstinence through treatment or high level of risk, but it uses a 12-month time frame. 7 questions, all levels of risk with a 12-month time frame. And the second validated screen is the CHISPA. It stands for cocaine, heroin, IV drugs, synthetic pot, and alcohol. In Spanish, it also stands for SPARC. Now, the CHISPA is actually was developed to be used following a positive CRAFT. It's a clinical guidance tool, and what we like about this one is that it uses a 3-month time frame, and it asks questions about substance use, the frequency of use, adverse events that may happen, student readiness to quit or reduce, and attempts to quit. And the CHISPA can also be used for monitoring change over time and monitoring treatment plans. So what I'm going to show you here is we're going to do a walkthrough of the questions on the CHISPA. The look and feel of these on the screen are what you would see on an electronic health record, or I'm sorry, an electronic tool. The questions are all the same on the paper tool, it just looks a little bit differently. So the substance use questions are broken out into three categories. It also includes alcohol. We're looking at uppers, downers, and recreational drugs. So students have an opportunity to check off which of these drugs in the past 3 months they've used. So the first question is about alcohol. Which of the substances listed below have you used any time during the past 3 months? And students would check off yes or no to any of these questions. So you'll see the uppers right below that, amphetamine, cocaine, drugs to treat ADD or ADHD. The next set of questions are about downers. Which of the substances listed below have you used any time during the past 3 months? It asks again to remind the individual that it is a 3-month time frame. In the past 3 months, have you used pain relievers, tranquilizers, heroin, methadone, or street view or Suboxone? And lastly, we have recreational drugs. Again, you'll notice that it asks during the past 3 months as a reminder again to the individual that we are looking at current use. It asks about marijuana, synthetic marijuana, hallucinogens, club drugs, Special K, anything that you can huff. And there's also a space for other substances. As we know that other designer drugs are coming out, and so it gives an opportunity for the adolescent to check off if they are using something new that we should be aware of in our clinics. We also look at frequency of use. So now that we know the myriad of drugs that you might be using, drugs or alcohol, how often are you using these substances? So it asks again, on how many days during the past 3 months did you usually use alcohol or drugs or other substances to get high? So we have a very low use of 1 to 3 days per month, excuse me, 1 to 2 days per week, 3 to 4, 5 to 6, and 7 days for those heavy users. Adverse events. The CHISPA asks there are 2 screens that talk about the different adverse events that might occur when you are using substances. So it asks, during the past 3 months, when you used alcohol or drugs, did you black out or pass out, use alcohol? In other words, are you use alcohol with any downers? Are you mixing substances? Are you driving while you're intoxicated? Have you had 4 or more drinks of alcohol? So we're looking at binge drinking as well in this set. Injection in drugs or substances. Injecting drugs could then trigger a medical test for Hep C, Hep B, or HIV. And then how much alcohol or drugs did you use so much that you are having to be taken to an emergency room? So how severe is this problem that you're blacking out, that you're experiencing adverse events that you have to go to the emergency room? It also asks about behaviors like sex without a condom. Are you getting into physical fights? Are you being injured due to the fights or accidents and having serious conflicts with family members? The last 2 questions are very important for the motivational interviewing. So that for that behavioral health intervention, these questions for you as a provider can tell you more about where that individual is in their motivation to quit. Have they ever tried to quit, or do they want to quit? Do they feel like they want to stop or reduce using alcohol or drugs? So now that we've talked about the craft and the CHISPA separately, I'd like to show you what the Sbirt flow looked like in the school-based health centers, so you can get that bigger picture of what it would look like. that graph on the left it may be a little bit hard to read, and so I outlined the 5 steps on the right-hand side. So in the clinic, in the school-based health center clinic, the Sbirt flow looked like this. The first thing that was done was the CRAFT, the universal screen with the CRAFT was administered. Now remember, CRAFT positive is 2 or more yes responses to those 6 questions. If a student had a positive screen, we administered the Sbhc, and that's the frequency of use with the 3-month time frame, the substances used, the adverse events, and the readiness to quit or reduce. You would then perform a brief intervention in step 3. The brief intervention would be, first you would sit with the individual, the youth, and review the information that you gathered, and perform that brief intervention. That's the opportunity for you to invite, using that motivational interviewing approach, you invite the individual to discuss the problem, to have a conversation, to tell their story. And if indicated, you would refer to treatment. And the treatment can be, as we discussed earlier, a warm handoff to a behavioral health or medical provider within your own clinic, within your own setting. And lastly, you can use the Sbhc to follow up. So you would schedule every 3 months out and administer the Sbhc to monitor the progress, as well as to change the treatment plan. So you may want to adjust the treatment plan after having administered a follow-up Sbhc. And this slide gives you a little bit of an overview of what the clinic flow would look like. So we know what the Sbirt flow looks like in terms of the tools that you would use, and this is what it would look like as a clinic itself, in the clinic setting. So for the first place you would go, we look at is the waiting room. The waiting room is that environment where, hopefully there's a space for the individual to take the screen on their own in privacy, so that they don't feel pressured to check off or not check off specific responses. So you administer the health screen with the Sbhc if warranted. You move into the exam room, so you have the provider as well as the adolescent in the exam room, and you both review that screen and talk about the problem. You perform that brief intervention. You use your motivational interviewing skills still in the exam room, and then you refer to treatment if possible or necessary. And the last step is that you want to document in the EHR. So what we've found is that oftentimes providers are reluctant to use billing codes or DSM codes that refer to substance use. There is a stigma around some of the use of some of these codes, and so sometimes the providers are reluctant to use them. But you want to be able to document in the EHR somehow that there was a substance use problem, so that there can be some follow-up with other providers. So what does successful integration of Sbirt look like? If you are planning on or would like to implement Sbirt in your clinic, there are a few steps that you might want to consider before doing that. So the first thing you want to do is identify an agency champion, someone who is really going to spearhead that effort, is going to lead the way. And you want buy-in from the leadership. If you can have a leadership buy-in, then you can access resources that may not be readily available to you if you just try to do it amongst yourselves. You want to have a clear clinic flow, so you want to really be thoughtful, just like we saw in this slide here. You want to be thoughtful about all the steps that will need to be taken, who's involved, what kind of staffing is needed, what sort of procedures and protocols need to be put in place to have a good clinic flow. So you're looking at the beginning all the way through the end to the EHR. You want to train your staff, and as I said earlier, you want to train even your front desk staff, all of your ancillary staff, because they are part of the Sbirt work. They are those folks that will interact with the patient beyond just that clinic visit. You want to use evidence-based tools such as the CRAFT, the S2BI, or the Sbhc. And you would also want to have established protocols for documentation. Every clinic looks different, so you want to understand what documentation looks like in your clinic and how that would happen for the evidence-based tools that you would be using. This is a slide, a summary slide of what the implementation looked like in our school-based health centers. So at the end of the day, we implemented Sbirt in 76% of the school-based health centers. We trained 104 providers. 68% of all the high school students in the New Mexico school-based health centers were screened, and we had a 17% positivity rate. So in other words, 17% of the adolescents screened positive and are receiving some sort of follow-up care. So what do we really know? This slide right here is a summary of an analysis that we did from the patient satisfaction survey that is administered on a yearly basis by the Department of Health. And what we found in our preliminary analysis is that when providers, and this is a self-reported survey by adolescents, so they told us that when providers are asking about substance use that they're using or substance use, adolescents reported greater satisfaction with the care they received. So in other words, actually asking the question makes a difference. And this really underscores that idea of having universal screening. With universal screening, you have a strategy to ask the question, and asking that question makes a difference in the experiences of care for adolescents. So just in closing, we know that the cost of healthcare is rising, and identifying ways, preventive strategies to address long-term health outcomes is really of the utmost importance. That's all. I hope that you found this information helpful and informative. I'll open it up to questions now, and I'll turn away from the camera. And if you would like a copy of the CHISPA or have more questions and need more information, that's my contact information for you.
Thank you, Daisy.
Thank you.
A couple of things come to my mind after your talk, and the first thing I want to say is thank you for the point on universal screening. As a social worker, as someone who works in primary care practices, working with docs on early childhood screening issues, that concept of coordinated and proactive and universal, so that everybody walks through your door and gets the same care, right? And that it takes some kind of pressure off a provider to not have to look at somebody and say, oh, I should probably screen you, or I should, and it also puts that judgment away. We're just going to do it for everybody because you might be surprised at what you pick up. Right. So I appreciate that in your training model for Sbirt, that concept. Universal.
Yeah, and I think oftentimes we know that providers have very limited time, and sometimes it is impossible to ask every question or think of every question that you need to ask. So with having a standardized screen, universally screening, you can very readily look at the information, and really the key is the conversation that you're having. Right. So even though you're doing a standardized screen, you want to be able to have that conversation. You want to talk more about it, because sometimes we do know that adolescents in particular may not answer all the questions readily. Right. Oftentimes they do, especially in this day and age where they're so used to going online or just answering questions. Their lives are very open. They'll answer correctly, but sometimes they don't. So it's that interaction, right, and with the provider that is very, very important at the end of the day.
I think it's important to, on the youth and family side, to hear that we do this for everyone. We're not only is the provider not weighing, is this a potentially high-risk youth, but the family isn't being singled out as somehow being high risk or identified. This is everyone. So I think that takes away some of that,
the stigma,
potential stigma.
Absolutely.
But one of the things I was wondering about when you were talking about, I understand documenting in the EHR, and you mentioned a reluctance to use billing codes. And so my question, and I'm not sure that this necessarily is the same in school-based health, but if you are in a primary clinic somewhere, or your private practice, those billing codes go back to, in some way, to the family, or could. How do you safeguard the youth?
That's a very good question. That's a very good question, and I don't have a very good answer for you. So, as we know, there are so many EHR systems out there, and each one of them functions very differently. So it's very hard to understand how one compares to another. In the school-based health center, I do know that some of the EHRs that are used have a space for confidential services. That is, it's more on the behavioral health side where all of this documentation happens. So it's confidential, it's hidden, it's not available to the parents. In some cases, we understand that clinics have it's basically foregone revenue. They don't bill for certain things because they know that they want to maintain that confidentiality, so it's foregone revenue. So those are two ways that I know people are protected, their information is protected. But I don't have a very good answer for you yet, and I don't think any of us have a clear picture yet of what that might look like.
I mean, I could see why some clinicians would be hesitant to, and yet it is certainly regrettable that that you would forego revenue. I mean, not in a sense of I want to enrich myself, but in the sense of recognizing just how important this level of care is, and having that acknowledged in the work that people do. You need that revenue at some level to turn around and keep providing services.
To be sustainable. Yeah.
Absolutely. Absolutely. You do need that revenue for sustainability. And I think the more and more that we implement universal screening and talk about substance use, the less stigmatized it becomes. I mean, it's no secret that New Mexico has a very high-risk population. And the more we talk about it, the more comfortable I think people will become and understand that preventing the issue, addressing it now, really goes a long way with impacting the long-term health of these adolescents. So that's why we do these trainings and we advocate for screening. But thank you for that.
One other note was around the depression and anxiety, having been in schools before in my prior life when I was doing clinical services. Thinking about the depression and anxiety, where that slide that you had, that substance use right early on is related to, I also think it's the other way, that it's one of those circle the drain things that's oftentimes teens will use to manage their depression and anxiety, right? They're like this. And if you can get in with some of that MI, and maybe help them figure out some strategies that you can cope with that anxiety without getting high before you come to class. You know, and to have those kind of conversations, I think it's interesting that they're like this, and you can't really say which one comes first.
You're absolutely right about that. And I know that some, with the Hilton work that we're doing, some of the grantees are looking at a more socioecological model. So they're so in terms of anxiety and depression and that relationship, we're looking at environments, right?
Right.
There are environments that we cannot control in the clinic setting, but we can open that conversation. We have an opportunity to at least ask the question and treat that individual. Other grantees are looking, like I said, at the family. How does the family interact with individuals who are at risk for substance use? How do you address that with families? Unfortunately, we weren't able to do that work here. We had plenty on our plate, but it is something that we have thought about, and that speaks to care coordination. How do we coordinate care better so that we can, at some point, include families in the conversation, right? When you are screening for anything, there does come a time in some adolescents' lives that you have to include the family. So that's a conversation and a clinical judgment for the provider. At what point do I feel like I want to help this young person share with their family, so that we can look at that environmental factor. Mhm.
One of the other things I was wondering about is I was looking especially at some of those early slides with the types of substances that are being used. What do you all see, or do you have any data on how many kids are actually using prescribed drugs? I know it's in the CHISPA, but how many of these young people are either prescribed something for, you know, injuries or something of their own, or appropriating drugs, prescription drugs from other family members?
So we are actually in the process of analyzing that data. We've collected data for the past 3 years on just all of those things. And because we have a high rate of opioid use here in New Mexico and prescription drugs, we are looking at those measures. But I don't have a final number yet. But I believe in the preliminary data, it was quite high. Something like 20%, which is higher than the national. But don't quote me on that. That's if memory serves me correctly. But we are going to look at that at the end of the day.
Any other questions?
I have one. How do we really reiterate that this is confidential and get truthful answers from adolescents? I remember like my freshman year of college, we had to do one of those interactive, like alcohol online things, and there was a rumor going around like they actually look and then they're gonna come, investigate, and then you're gonna get in trouble. So no one was answering truthfully, and I just wonder how do we make kids feel comfortable answering in the right way?
So in the school-based health centers, we do, there is a form that parents and, there's an agreement basically between the parents and the clinics that there are certain services that are confidential. The parents will not, really learn about unless it's warranted by, and it's approved by the student and the provider. So at the very beginning of the clinic visit, there is a statement that the staff read off to the young person so that they understand their rights. And there's also a Know Your Rights campaign that informs young people about what their rights are for confidentiality. So that's taken care of in the school-based health center setting. In the clinic setting, I understand that it's a little bit different. And again, I don't know that I can answer that question because every clinic works differently. Right. So
that'll be part of what we get to work on next semester with Tessa and that adolescent health toolkit, because that's all about training providers to provide adolescent-focused, friendly, private, and confidential care.
Right.
And so we can explore some of that, how you set that dynamic up, and
so they believe you.
so that they believe you and that you act in a trustworthy way and set the space so that it feels like this is private and confidential between us.
Yeah.
So that's good.
Great. Yeah. Thank you.
You're welcome.
Thank you for doing this, Daisy. It was
You're
great
welcome.
and informative.
Thank you.
Good. I'm glad you
Have a
enjoyed
great
it.
day.
Thank you.
To no one in particular, except for us around the table.